Hello, and welcome to the Becker's annual meeting virtual event. We are so excited to have you join us for our next featured session, Expanding Access to Innovative Technology to Advance Health Equity. On behalf of Becker's Healthcare, thank you for joining us today. Before we get started, I'm going to walk through just a few housekeeping instructions. If you have any questions throughout today's presentation, you can submit those by typing them into the Q&A box you see on your screen. If at any time you do not see your slides moving or you have trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we are here to help. This session is being recorded and will be available on demand following today's event. We will send you instructions on how to access the on-demand recording once the event concludes. And with that, I am pleased to turn the floor over to Matt Nierengarten, who will moderate today's discussion. Matt, the floor is yours.
Hello, and welcome to today's session. My name is Matt Nierengarten, and I'll be your moderator. Today's breakout is focused on the title of Expanding Access Initiatives to Improve Patient Care. Dr. Kent Bishop is joining us from ProMedica Health, located in Toledo, Ohio. Dr. Bishop is the Chief Medical Officer at ProMedica. Welcome to today's program, Dr. Bishop.
Matt, thank you so much for that kind introduction. I'm really excited to speak with this group today. I know we have a group that's committed to minimally invasive surgery and really improving access and expanding access to the patients that we care for. At ProMedica, we're really proud of what our organization is all about. We see ourselves as an integrated health system. We're located in Northwest Ohio. We have 12 hospitals. We've got a physician group that has about 1,200 providers. We have an insurance plan, and we also have the largest not-for-profit senior care division in the country. That senior care division expands over about 29 states. In all, we're about a $7 billion revenue operation, and we have about 50,000 plus employees. Something that's near and dear to my heart as an OBGYN that really started doing robotic surgery in 2010 is just really the growth of our robotics program and minimally invasive program as a whole. One of the best things I get to do is work with young surgeons, and we are really fortunate to have a cadre of surgeons that, in my view, parallel to anybody in the country with their skill set. We're doing state-of-the-art technology using this robotic platform, and we really feel like these surgeons can allow us to really grow as an organization and really provide the kind of care to our patients that they deserve. This is just a snapshot of our organization. It tells our story, really. We started as a legacy hospital system that grew like most other hospital systems to acquire other hospitals and other organizations and doctors' practices. I was the 8th doctor in PPG, and now we're up to 1,200 physician providers. In addition, we took on an insurance plan and then ultimately the senior care division. But something that's really core to our beliefs is that a few years back, we started really screening for and looking at causes of childhood obesity. And we really found out that it was really because people were struggling and they were food insecure. And that journey has been something that is the backbone and kind of the bread and butter of our organization. It's really adhering to and learning about the social determinants of health. While the technology that we have in robotic surgery is just amazing, so much of healthcare has so much to do with, where you live and where you go to school and the transportation that's around you and other social factors. And that's not lost on our organization as a whole. So while these numbers are great, we know we don't really lose our mission. We see ourselves as an anchor institution that takes care of the communities that we serve. And that's really what I think allows our providers to kind of bounce out of bed every single day. Really, really proud of that. Now, that said, there's no margin. With no margin goes no mission, right? So we have to do things in order for us to take great care of patients, but also make sure that, we have a margin that can allow us to really give back to the communities that we serve. And since 2007, we've done over 22,000 robotic surgery cases. And I started doing robotic surgery in 2010. There was about one other gynecologist doing that. And this has really been a passion that I've been able to kind of work on. And now I'm fortunately surrounded by a bunch of young providers and administrators that have the same passion. And we talk a lot about teams. And if you're on this call, you're thinking about how can you expand your current services. I would tell you that you will not do that unless you expand the capabilities and capacities of the teams that work for you. And I think that's a really important point. And I think that what I want to share with you is you have to tell the story to everybody on your team. Your team needs complete buy-in. The CRNAs need buy-in. The nurses rolling the patient, that check the patient in, the staff that rolls the patient to the OR, they have to know that the care that's delivered to this patient and how fast that patient recovers and the lack of complications that patient has to suffer. All of those people that work in your system need to be privy to that concept. And that requires your surgeons and your administrators to be really good storytellers, because unfortunately, the people in this process that patients go through don't always get to see the end product unless they're a patient themselves. So I would really encourage you, as you think about how you're going to expand services, it's really telling your story at a really, really high level. Fortunately, today, you're not going to listen to me the whole time. So I've got a young surgeon, that our GYN oncologist, he's actually the head of our cancer division, Adam Walter. And then also a young star that we have that's an operator, Thad Wadsworth. Thad has worked in just about every position within an operating room, and now has just continued to ascend within our organization as an operational leader and now president of one of our regional hospitals. So, when we looked at how are we going to expand access, it really started with a tenet that we start with was, we want to reduce open surgery as a whole. That has to be a commitment that has to resonate with both the providers all the way up to the C-suite. And I think we did that in kind of fairly record time in collaboration with Intuitive and really just having our C-suite understand the importance of reducing open surgery and the complications therein. In order for us to really make sure that we can expand access, we have to make sure that surgeons really understand that they have capabilities to the interventions. So how do you do that? You have to have capable teams, you have to have the technology in the right place, and you have to have an understanding and a belief in the fact that this is the right thing to do. Even if it takes a few more minutes to get something hooked up or assigned or make sure that all the equipment's where it needs to be. Ultimately, we really felt like this is something that we wanted to press on with and something that really could differentiate us as an organization. Next slide, my partners are going to talk a lot more about each of these individual pockets, but just to oversee it, it really comes down to having the right technology, having really competent teams, and then figuring out how do you utilize the scarce resources that we all have. I will tell you during COVID, we actually repurposed an orthopedic spine hospital, moved a robot to the orthopedic spine hospital so we could do our cancer cases so patients would not have delayed care. That doesn't happen without complete buy-in from our organizational leaders, the company at Intuitive that we deal with, and all of our surgeons who know that expanded access to care really can be a differentiator. So let's talk about your roadmap to success as it relates to robotic surgery. I think we started with just a belief with all of our shareholders that reducing open surgery, no matter what the venue, no matter what the time of day, no matter where the location organization, has to be a priority. In order to do that, you had to have the right technology at the right place. And we worked really hard with our partners at Intuitive to make sure we had the right model. And that meant really saying, hey, our technology needs to match. We need to have the latest, greatest technology at each of our locations. We can't spend 3 or 4 years having technology lag and having surgeons not have the capabilities and the technology they need in order to be successful. Behind the scenes, you had to build competent care teams, groups of nurses, groups of anesthesiologists, people that understood the difference between this platform and how do you make this platform really hum. And I think Thad will talk to that later in this broadcast. We are continuing to seek an open access program, one where you can pretty much do Da Vinci surgery 24/7. I'm not going to lie to you and act like we've got that completely figured out, but I can tell you we are closer than we've ever been. It's with the help and the collaboration of our steering committees, our C-suite, our operating rooms, and our partners at Intuitive. I think a lot about how do you're on this phone call. So you are thinking about how can I expand access and where are the barriers to me expanding access? Maybe it's capital constraints. Maybe it's you have someone in the C-suite who just doesn't understand the importance of robotic surgery or really what it means. But I can tell you, I think if you really spend the time and understand your own data and be able to articulate that to your C-suite, hopefully that's one of the first steps. This next slide is really what I want you to understand. The amazing thing about robotic surgery, in my view, is it's been able to really change and actually reduce open surgery. We keep track of how many open surgeries we do that probably could have been done via minimally invasive route. It's my estimate that approximately 1/7 of the open surgeries that are 1/7 of the total surgeries that we do probably could be reduced to a minimally invasive approach. And that's quite a large number throughout our large system. So how do we get there is really the key. And it's, in my opinion, is taking your data and understanding your data. You might have one robot right now. But that robot is pouring out data. Maybe it's length of stay. Maybe it's reduced infection. There might be some things in your data that don't look so good. Maybe those cases are taking a little bit longer right now. But I can tell you, with the further commitment, you'll reduce that time in the OR. And if you really think about it, almost everything on this slide will ultimately occur. We've seen improved operating margins. We've seen reduced length of stay. We've seen lower readmission rate. We've seen the goals of our organization met through the use of minimally invasive surgery. And to me, the story starts to tell itself. And I think that is the key. How can you be a great storyteller? And how can you make sure that people understand that this technology actually will deliver when it's in the hands of really highly skilled surgeons with teams that are really expertly trained and committed to the same purpose? So the best part of my day now is get to hand off this to Dr. Adam Walter. Adam trained at our OBGYN program and then did his GYN oncology fellowship at the University of Oklahoma and is now back with ProMedica as a GYN oncologist, and he leads our cancer division. So I'm going to hand it off to Adam.
Thanks, Dr. Bishop. Hi, everybody. Thanks for being here with us today. Privileged to talk with everybody today. I'm Dr. Adam Walter here at ProMedica Cancer Institute. I'm the medical director as well as a GYN oncologist here, and super excited to speak with everybody today about robotic surgery. So primarily, I'm going to talk a little bit in detail about right technology and right place. This is something that's very near and dear to my heart after we've gone through the recent COVID pandemic. Dr. Bishop mentioned a little bit earlier, but we're going to kind of jump into this in a little more detail. So first and foremost, I came back to ProMedica approximately 6 years ago. And when I originally re-entered the team here at ProMedica, we had S robots, we had SI robots, we had X robots, and then we had the XI introduced. So at the same time, we had 3 and at times 4 overlapping platforms. And the challenge of navigating between all of those things as a surgeon, as a team, as a sterile processing department, where are the instruments and which robots do we have at what hospitals, became a really big challenge for us as a health system. So for our purposes, the AMP model and being able to upgrade and standardize our fleet not only made it unbelievably more simple to acquire the skills as a surgeon, but not only that, but also as we continue to train our teams. We didn't have any challenges about which instruments fit which robots. Does this one dock from the side? How does the boom work? If we need to do 4-quadrant surgery versus 2-quadrant, do we have to dock, undock, et cetera? So standardizing that across the board made it much more simple for surgeons, staff, sterile processing, et cetera. So reducing that variability at every level was a huge key for us in being able to not only do more cases, but do them more efficiently. The other thing that really became a big challenge between sites was we had different robots at different sites or different robots at the same site, trying to figure out which instruments we needed, cleaned, ready in the right kits for the right cases, became a nightmare for sterile processing. Standardizing that across the board with our X and XI platforms has made that unbelievably smooth. I need a new scissor? Great. We'll send one up. It's not, let me go look and see which scissor we probably maybe need for this room that I think you might be in. So that's helped immensely. And then overall, it just improves satisfaction across the board. It improves provider satisfaction. We're not waiting for things. You don't have to specifically request a room with a specific robot for a specific procedure that you're trying to do. And overall, it just facilitated better adoption and utilization, instruments, staff, et cetera, made it much more simple across the board. So if your fleet is not standardized, that's an unbelievable key for growth. So I think the other key is really building a strategy that individualized to our sites. So whether you're talking about the main hospital or in our situation, ambulatory centers, et cetera, who's doing what cases and where? So for your system, it may be, do you have a women and children's hospital? How does that look? Probably pretty rare that you're going to be doing foresight surgery there. So maybe a more specific X robot makes sense there. Are you doing thoracic surgery? Are you doing complex abdominal wall reconstruction, et cetera? What's the plan at that site? And then individualizing what you need based on what you're planning to do at that site without limiting your growth potential there. It really also helps us identify staffing needs. Yep, we have 4 robots. We're planning to run 3 of them, 4 of them all day, every day. Nope, 2 of them we're going to shut off at noon. Nope, we're only keeping 1 or 2, or all 3 or all 4. How many of those can we run after hours, et cetera? Really dictated also by the number of surgeons that are utilizing the technology, and that revolves, right? Especially as we're coming through summer months, into fall, into winter, where different surgeons may be taking different time off. How are we best utilizing an unbelievably precious resource without having gaps in being able to use that and giving our patients best access to it? So really identifying and individualizing what the goals are at each site and really tailoring the approach to each site. Big deal. Dr. Bishop mentioned this before, but really, what is the ambulatory surgery strategy? So lots of procedures that have been done in the past in an open manner were inpatient procedures, but they were only inpatient procedures because they were done in an open manner. So as we continue to push the boundaries of what we can do with minimally invasive surgery and specifically robotic surgery, the question becomes more and more, what's the expected recovery for this? Can we do this in an outpatient? Can we do this with observation? Okay, now that we've done 50 of these and we haven't needed to transfuse anybody or keep anybody overnight, is this a procedure that we can consider safe with reasonable limits to move into a lower cost, more efficient setting? It's a really, really good question. It's one that we're reevaluating all the time, especially as we gain more experience with more procedures and more surgeons. So I would really explore that thoughtfully now, because if you have an existing ambulatory surgery strategy, or if you're looking at redesigning or re-implementing something, make sure that you are having space considerations to accommodate minimally invasive surgery in your ambulatory surgery spaces. In our situation specifically, it's really helped to decant the main OR. We do a ton of more complex, multiple surgeon team cases at our main ORs, and we've been able to move lots of these other cases that have become more straightforward as we've had more experience and become more facile with them out to our ambulatory surgery centers. It's been an incredible opportunity for us, more as surgeons, to have more time, more cases, but also for our patients. Hey, can we treat you closer to home? Can we do it safely, et cetera? That really speaks to the expanded geographic coverage. Unbelievable access in our regions. So used to be probably 5-6 years ago, everybody that needed robotic surgery has to go to one place. Why? Well, because that's the only place we have the technology. Okay, well, if we move the technology closer to you and we have surgeons that have the ability to do it, can't you have it 2 minutes from your house as opposed to getting in the car and driving an hour each way? Absolutely. So we've made intentionally those choices as we move forward as a system. Also, especially regionally, how do we capture new revenue streams? Not only doing newer and more complex and multiple team surgeries, But if we offer a procedure robotically in your geographic location that's minutes from your house with somebody that's qualified to do it, what's the reason that you would have to go anywhere else? This certainly aligns with our physician goals. I don't think any surgeon gets real excited in the morning to wake up and see how many patients they can round on in the hospital. We love minimally invasive surgery. It allows us to do better for our patients. It allows us to do better for our morbidity and mortality numbers, and it does better for our lifestyle. It's a win-win-win all the way around. And then really it allows us to develop much lower cost offerings. So if we can migrate cases that we become more facile with after a tremendous amount of experience, yeah, we can move those to ambulatory surgery centers. We don't have to worry about admissions, especially in an era as we've all struggled in the last year with inpatient volumes and inpatient access to beds. So really, again, this really talks about the site of care shift. This is really an outpatient shift and an outpatient strategy. So can we provide safe, reliable, high quality, repeatable care across multiple surgeons in a lower cost setting? That's a win, not only for us as surgeons, as patients, as insurers, as hospital systems, et cetera. It's just the right thing to do. We believe that here at ProMedica, and it's something that we're committed to reevaluating all the time. This is something that our robotic steering talks about sort of ad nauseum. Hey, how many cases are we doing? Where are those cases landing? What are we doing to move cases that are appropriate to lower cost settings? Stakeholders that drive surgical procedures to our outpatient departments and to our ambulatory surgery centers really, I think in our situation, started with a conversation between the surgeons and our ambulatory surgery staff. What do we think is safe? What do we think is reasonable? What do we try? How do we make sure that we're keeping people safe? So I think it was driven largely by probably surgeons, but also largely by our ambulatory surgery staff, who are unbelievably talented. And then as we build more and more trust within our ambulatory surgery teams over time and gaining experience with a number of procedures, easy to offer this to patients. Patients love this. It's really easy to navigate an outpatient surgery center when you're talking about comparing that with an 800-bed hospital. Yeah, I get to park 50 feet from pre-op. My family knows where I am, and it's an easy ride out. I can see my car from my hospital room. And then, of course, payers love this as we move to a lower and lower cost setting. I think the big thing when we're talking about MIS shift to outpatient settings is really, it's also being driven by cost, of course. Just some data here showing massive differences in cost to treat between benign hysterectomies inpatient and outpatient, and ventral hernias inpatient and outpatient. If we can do these cases safely for patients, it just makes sense to move this direction. So critical access hospital strategy. I think this is a big deal when we're talking about market share, and really when we're talking about decanting our tertiary volumes by keeping patients in a rural setting. The big deal here for us is that as we've had more surgeons and more complex cases that have moved into our main hospital, we don't have time to do all the routine cases, transferring patients in, having them drive hours back and forth. It's really made sense we need everybody trained. We continue to see this technology as the future. We train every surgeon that can be and wants to be. And we make it accessible the same as you would a lap tower. It's a really, really big deal that all of our staff, et cetera, this is not some magic wand, but it's a piece of equipment that benefits our patients. And then again, as we think about recruiting and retaining surgeons, yeah, this is a huge deal for retaining and recruiting surgeons to more rural areas. You have the same access technology that we have in any of our hospitals. It's really becoming part of our brand standard. And then again, creating 24/7 access to Da Vinci, after hours, nights, weekends, holidays, open access for all cases, including emergent cases where appropriate, dedicated ORs for robotic cases, and then really leading to global staff training for support, whether it be during the day, at night, weekends, whatever. Really standardizing our fleet has made this feasible, and we continue to push for this all the time. I think there's a lot of additional considerations. Evaluating system placement based on utilization. I think in the last 2 years, we've probably moved robots, I don't know, a dozen times to places that they make sense based on what surgeons are doing what cases and where. Considering robotics for all sites of care where your surgeons are prioritizing MIS, just setting them up for success. Dr. Bishop alluded to this earlier. Sharing your success stories with the anesthesia and care team members is unbelievably important. So what a staff member sees when I do a robotic surgery is Dr. Walter wants to sit down and do a hard case. What they don't see is an unbelievably ill patient that's 400 pounds, had a very complex surgery and went home the next day, and we minimized their complication rate by tenfold. You have to pass that back, and you have to also be transparent when you talk with your patients afterwards and they say, my God, I had an unbelievable experience. Yeah, we have a great team. And that starts with the nurses in pre-op, that extends to the operating room, our care teams afterwards in recovery, and then to the office as well. And then also vitally important for our system was partnering with Intuitive to build and execute this strategy. It's important. This has to be a plan. This doesn't just show up overnight. All right, I'm going to turn it over now to Thad, and he's going to talk in more detail about alignment with OR leadership teams. Thank you very much.
Thank you, Dr. Bishop and Dr. Walter. I'm Thad Wadsworth, the president of Bay Park Hospital and Wildwood Orthopedic and Spine Hospital. You've heard the importance of aligning with executives, building an enterprise-wide strategy to reduce open surgery, and insights on the right technology in the right place. However, the most critical step of achieving unfettered access for robotic surgeons is operationalizing the strategy, a concept that is often simple in design, but can become complex in deployment. Similar to aligning with the C-suite, it is essential that OR leadership and care teams are educated on why Da Vinci. Change can be difficult, particularly in challenging times. It is important to align the care team from the beginning on how robotics and minimally invasive surgery drive better patient outcomes, and if done correctly, a more efficient OR. At ProMedica, we place a premium on cooperation and alignment to drive OR strategies. Robotics is no different. Our first step was to educate and align with nurse leadership, surgeons, OR teams, and anesthesia, getting all parties on board and understand why robotics. It is vital that everyone understands the impact of reducing open surgery and the role that robotic plays in the bigger strategic organizational plan. When driving alignment in the OR, you will typically hear two primary objections. Robotic cases take too long. Robotic cases are more expensive. One powerful way we have overcome these objections and driven alignment is keeping the patient experience front and center. This is an example of how one of our general surgeons quantified the impact that Da Vinci has had on his patients and surgical practice. What you see here is Dr. Jamil is routinely doing hernia cases in an hour or less, which is below both our IDN average and the national average. Additionally, Dr. Jamil is improving the margin per case compared to open and laparoscopy methodology by completing his hernias with Da Vinci technology. His patients are going home faster, experiencing less complications, and have lower readmission rates. But perhaps more importantly, Dr. Jamil's Da Vinci patients are having a better total patient experience. The robot has allowed Dr. Jamil to significantly reduce the amount of opioids prescribed. It's important to share this data with your OR and anesthesia leaders to both dispel the misinformation about robotic surgery, but also open their minds to cooperating on an expanded access strategy. After alignment is achieved, the next step is establishing an education program to train your entire staff to support robotic procedures. Ensuring our care teams receive the education support needed to feel confident is paramount. Intuitive has built an online learning system that our nurse educators have integrated into our Da Vinci training program. If you have not tapped into this resource, I strongly encourage you to connect with your Intuitive representative to learn more. Hands-on learning is a key component of training and best practices for in-servicing team members. Dry run is another effective form of hands-on training. This is an opportunity to go through the sequence of a procedure and ensuring that staff are comfortable with the workflow as outlined below, from OR setup to OR shutdown. A chart like the one seen here can be used to facilitate hands-on training and as a reference for newer team members during robotic cases. Along their learning curve at any given time, team members will have different levels of exposure to robotic cases. This concept is especially important when making second shift or call assignments. Try to mix and match so that newer staff have more tenured team members in the room to guide them as they acquire more experience and avoid scenarios where the entire care team is novice. Approaching assignments this way will create a more pleasant experience for the care team, but more importantly, consistency in care while still providing learning opportunities. Finally, an optimized block schedule for Da Vinci is needed to ensure that the right surgeons have the appropriate access based on their volume and practice dynamics. Block scheduling is another one of those topics that is simple in concept, but often comes complex in application. On this slide, I've highlighted some of the best practices that we have found to be extremely helpful in driving better utilization of both surgical capacity and robotic assets. So how do we bring it all together and manage our program? Our robotic steering committee has been invaluable. The robotic steering committee provides oversight for the program. It's a platform to consistently engage, communicate, and educate key stakeholders. And most importantly, it's a forum where decisions are made. As such, we have incredible participation. For example, we routinely evaluate and discuss block utilization and allocation in our meetings. This is a simple tool created to structure those conversations. You may use something different, but it's important to create a cadence of communication with all invested stakeholders and evaluate the program monthly or quarterly, depending on the maturity of your program. Thank you, and I'll now turn the program back over to Dr. Bishop.
So just a few key takeaways. First of all, we need to align our key stakeholders, evaluate our technology footprint, build confident teams that are competent, and also really try to manage that program through bringing those stakeholders together via a steering committee. Our journey has been an interesting one at ProMedica. Our initial relationship with Intuitive was very transactional. We bought robots. We tried to figure out how to make the technology last the longest. We really never had the right technology. There was always a new technology coming out, and we were chasing our tail. And over time, that relationship has markedly transformed. Now it's a shared vision. It's an idea on how we can really deliver the best care for our patients with the best technology, right place, right time, every single time. And the data that Intuitive has brought to us has been invaluable. And we continue to grow in this partnership and learn in this partnership. So I hope you've gotten some information that's helped you as you look to expand access to your program. Now, we believe in this technology. I know you wouldn't be on this call unless you believe in the technology. If there's anything we can do to help you in your journey, we'd love to do that. We strive to get better every single day, just like you. We're lucky to have the partners that we have at Intuitive. We're lucky to have the young surgeons on our team and the teams that are extremely competent that deliver the best care to our patients every single day. I hope you enjoyed our presentation. Thank you very much.
Well, thank you, Dr. Bishop, Dr. Walter, and Thad for that presentation. Glad to welcome you all back on screen here together so we can address some of the questions that have come in during your presentation in this panel Q&A setting. So I'm actually going to start the first question with you, Dr. Bishop. I know you mentioned that ProMedica has established a pretty big goal to aggressively go after open surgery. And the question is, how do you plan or how have you used this expanded access strategy that the team just walked through to work toward that goal of open surgery reduction? And how is it working?
So we've identified about 1,000, actually over 1,000 cases done in our system that were done open that we think could be transitioned to a minimally invasive approach. And we track that number regularly. In addition, now when physicians choose an open approach in cases that we believe could be done through a minimally invasive technique, they need to document why they're doing that. And I think that's the first step to reducing open surgery. The other thing that physicians will say is, I can't get block time or I can't get on the robot at your location. So that is a common concern that they used to have, and that in our growth of our robotic program and our commitment to reducing, open surgery, by having this expanded access, that is no longer really a reason that we allow to be given. And so we're going to continue to track that number. We expect it to go down significantly. We really haven't gotten that much pushback from our surgeons who do the bulk of open surgery, because I think they do deep down understand this is where the best return on the investment for the organization, but more so where the best outcome is for the patient.
Thank you for that response, Dr. Bishop. Dr. Walter, I'm going to ask the next question here that came in through our Q&A. As a surgeon leader, what data do you use to help compel or overcome challenging colleagues who may be standing in the way of strategies like expanded access?
Yeah, I think there are a couple, probably specifically physician level data. So looking at your own data and being able to compare it to peers, length of stay, readmission rates, emergency room visits, surgical site infections, pick anything, minimally invasive surgery almost always wins. I think the big thing when we're talking to surgeons that are adopting minimally invasive surgery or specifically robotic surgery, just making sure that we're having the conversation that there is a learning curve. So the big thing, if you measure early, OR time, yeah, the first one is not going to be as fast as you can do an open whatever. However, within the first 20, 30, 40 cases, depending on who you are, that normalizes pretty quickly. So especially as we have had more and more experience and standardization across teams, so that as our OR teams are more facile with docking and ports and instruments and all this stuff, it allows our surgeons who want to be trained and want to adopt robotic surgery, it allows them to step into it more easily.
Thank you, Dr. Walter. Thad, a question for you. This one is about programmatic governance. So with your steering committee that was discussed during the presentation, this question is asking, how do you review the access piece of your program? And most specifically, is there a dashboard? What type of data does your steering committee review to make sure that you're optimizing access for your surgeons across the network for robotics?
Yeah, we're lucky enough that we have a surgical services data analyst right within our surgery service line. So she has multiple dashboards where we track overall volumes per surgeon, minimally invasive and open. We also look at the utilization rates of all of our robotic assets across the system, how well we're using them. And we also look at the surgical block time that surgeons request and how well they use them. We have dashboards and we transparently share that data at our robotic steering committees, whether it's the system one or the local ones. And those decisions are made by that governing body. So we're really transparent with our data.
Fantastic. One final question, and I'll pose it to the group. Please, any one of the three of you can chime in first, but happy to hear the thoughts of all three of you. And simply put, the question is, what's next? I think, Dr. Bishop, in your part of the presentation today, you mentioned that full transparency, you haven't accomplished all the goals for expanded access that the team has set, but you've made tremendous progress. So for the group at ProMedica who's clearly invested so much in the technology, what's next for your team with regards to expanding access?
Yeah, I think it's the setting and guarding the culture that we're going to do the right thing for the patient no matter what. Doesn't matter what time of day, doesn't matter what day of the week, doesn't matter who the surgeon is. How do we continue to work together as a team, both physician, executive leadership, OR staff, anesthesia, recovery, whatever? How are we working together to ensure the best outcome for the patient no matter when they enter our system? And if we have that right culture, it leads to a place where we all push for this. It's not one person pushing for it and everybody's mad. It's we all push towards this because it's really at the end of the day about the patient. And if we continue to have that in the forefront of our mind and set that culture, no matter who we're talking to, we end up just doing the right thing. I think that's, in my opinion, that's it.
I think for me, Dr. Bishop told you the number of hospitals we have in our health system. We still have 3 hospitals that sit out in our rural setting, probably the 3 farthest from our Metro Toledo market that do not have robotic technology. And I'm happy to say that we are currently working to launch robotic programs at 2 of those hospitals, and we're pretty far along the journey of a feasibility assessment on the last remaining hospital then that does not have the robotic program there. So really proud to have that technology at every single hospital that's branded ProMedica here in the near future.
So I would just add that, I look at it, what can we be great at ProMedica? And in my opinion, as I look across as the chief medical officer, I see that we can be great at minimally invasive surgery. We can drive down the number of open cases and thereby really see the benefits to our patients that we serve. We are, as I mentioned earlier, blessed because we've got a group of young, talented surgeons in almost every single division that are doing state-of-the-art robotic surgery currently. And some are being viewed on a national platform, and whether it's bariatrics or gynecology. And I can tell you that we feel like we can be a center where people can come and learn from, because we want to be transparent and really open to what we're doing on a regular basis, and the kind of care and cases that we can both perform and care we can provide. So we think we can be great at reducing open surgery and minimally invasive approaches. And we think we're aligning our technology with our people with the benefits of Intuitive. So we're super excited about the future.
Well, thank you, all 3 of you, for your responses. Most importantly, thank you for taking the time to participate as faculty for this panel. We hope that everybody got some valuable insights today on how to operationalize an expanded access strategy to make an impact on patient care. Quick reminder to please do, if you have not yet, answer the questions on the survey, as we are always looking for opportunities to improve these programs. Thank you for joining us today.